Today's an exciting day. It's our second Innovations Conference, and I think the real measure of success for today is that last year people took some of the innovations, have gone back to their practice, implemented them, and today are reporting on some of the outcomes of those processes. That's really exciting to see. The other excitement for us as an agency is that next week we turn 10. And as we reflect on what has been achieved over the last 10 years by having a government agency committed to cancer control, we can be really proud of what has been achieved. What has been achieved in prevention with massive reductions in smoking across our community, so that New South Wales now has the lowest smoking rates of any of the states, and we couldn't say that a decade ago. Increasing participation in screening programs, real innovation happening at a systems level in service delivery, some resources that are leading the world, such as EVQ and Can Refer, and a very real investment in research. Importantly, we've got a wonderful workforce delivering some of the world's best outcomes in cancer care. We've benchmarked them with the people we consider to be the leaders and our peers around the world. But despite that, we've got a way to go. And the reason for having an Innovations Conference is quite simply because we know we can do better. It's not about how dedicated we are as individual clinicians, policymakers, funders. This, more than anything else, is about how we make the system work more effectively for each person who is diagnosed with cancer. We know that we can make a difference, and so I hope from today your goal is to take away one or two ideas that you can apply within your setting over the next 12 months in order to report back next year about the differences that it has made. It's my very great pleasure this morning to welcome Uncle Chicka Madden to welcome us to country. We appreciate you being here this morning, Chicka, particularly realising that you do need to get away because of family illness, but thank you so much for being here today.
Yes, thank you, Dave. Pardon me. My name is Charles Madden, known around the inner city as Chicka. That's a nickname I got many years ago going to Redfern Public School, which is now NCIE, the National Centre for Indigenous Excellence. I've grown up in and around the inner city, especially the Redfern Alexandria area. As I mentioned, I went to school at Redfern Public School many years ago, between Redfern and Redfern Alexandria. Never ever went to that school. It's always Redfern and Uralla Public School, up in Thunderbolt country. I'm a director with the Aboriginal Medical Service. I've been on the board there for over 40 years. I'm also an active member with the Metropolitan Local Aboriginal Land Council, ex-member with the Aboriginal Housing Company Redfern, Aboriginal Hostels Australia. I'd like to take this opportunity this morning to extend a warm and sincere welcome to all my Aboriginal brothers and sisters, non-Aboriginal brothers and sisters. Welcome to Gadigal land. Aboriginal land, that's the land we're on at the moment. The Gadigal clan is one of 29 that makes up the Eora Nation. The Eora Nation is bordered by three distinctive landmarks. We have the Hawkesbury River to the north, the Peen to the west, and the Georges River to the south. Those three rivers form the boundaries of the Eora Nation. Folks, if you've travelled across this great city of ours this morning, the state or this great country, welcome to Gadigal land. If we have any brothers and sisters here from the Torres Strait or further afar across the seas, welcome to Gadigal land. If in enjoy the morning, have a safe and trouble-free trip home, and once again, welcome, welcome, welcome. Thank you. Enjoy the morning.
Thank you very much, Uncle Chicka. It's now my great pleasure to welcome the Honourable Melinda Pavey, Parliamentary Secretary for Regional Health, to the podium. We are incredibly fortunate to have a government that is focusing specifically on regional health and improving outcomes so that right across our community there are equitable outcomes in New South Wales, irrespective of where you live. It's wonderful to have a champion who really has taken this portfolio, made it her own, and it's wonderful to see the difference that that's starting to make in regional New South Wales. The Honourable Melinda Pavey.
It's very, very generous and kind of you, David. Thank you very much. Thank you, Uncle Chicka. That was a great welcome to country, and I'd also like to acknowledge the Gadigal people of the Eora Nation, who are the traditional owners of the land on which we meet today. I pay my respects to their elders past and present. I am delighted to be here in the 10th anniversary year of the Cancer Institute, to be at the second Cancer Services and Care New South Wales Conference. And I can tell you the Minister, Gillian Skinner, would really, really love to be here today more than anything else as well. She's stuck back in Parliament at budget estimates. So she's getting the grilling from the opposition, in about a 3-hour period, and it's just not one of the pleasant things of being a minister is going into budget estimates. She'll do a fine job, don't worry about that. But I'm just making the point that she would have been here, and I'm sure she'd much prefer to be here today. This conference focuses on innovation in service delivery, cancer treatment and care, and it also provides a wonderful opportunity for us to learn more about cancer through innovation. We can make critical differences to outcomes for patients across the entire New South Wales health system. I make acknowledgements of David Currow, the Chief Cancer Officer, and his Deputy CEO, Sanchia. This morning you will hear from two inspiring innovators, and I'm going to be staying to listen to them as well. Professor Jon Emery will share his work on enhancing the role of primary and community-based healthcare professionals across the spectrum of cancer: prevention, screening, diagnosis and follow-up. They are the buzzwords in terms of health and where we're going into the future. Being able to care for people, in a more primary space without the normal and hospital presentations. Being able to do it at home, hospital in the home, is certainly where we're heading. And Associate Professor Sabe Sabesan will tell you about his inspiring work in transforming a community in North Queensland by connecting 18 communities across 750,000 square kilometres into a single oncology practice. And I salute you for that, doing work for regional and rural and remote communities. And I know Sanchia is also very excited about that work and is bringing that to New South Wales as best as we can. And that's the future, and it's clever, and it's actually all about providing better services to patients. I'd also like to give a plug to Vanessa Connor from Coffs Harbour, which is where I'm from. She's going to be doing a platform today in full bladder technology, and I just thought that was a very interesting panel discussion, and I just thought I'd give a local Coffs Harbour person a plug. Many of the discussions that will take place today will explore themes that are central to continuing the improvement in cancer outcomes that we have seen in recent times in New South Wales. Improving cancer services, enhancing outcomes for priority populations, making innovative use of data and technology to improve patient outcomes, and improving care coordination. These issues are critical, and if we are to continue to maintain a responsive healthcare system. Equity issues, in terms of both access to cancer services and cancer outcomes for all people in New South Wales. It is particularly relevant to my work as Parliamentary Secretary for Regional Health. The New South Wales Government and previous governments have invested strongly in cancer services in rural and regional New South Wales and collaborated with the Commonwealth Government to provide regional cancer centres. We opened a new one up in Tamworth about 3 months ago, which is a great boost to the northwest of New South Wales. Regional cancer centres are making an important contribution to improving access to quality cancer treatment in rural New South Wales, providing cancer services that include radiation oncology, medical oncology and surgical oncology. I'm delighted to know that the New South Wales Government's important regional focus is also lived out through the Cancer Institute New South Wales initiatives. In 2013, the Cancer Institute provided funding to support the provision of care coordination and multidisciplinary care in rural New South Wales. The Cancer Institute has also formed a rural directors network aiming to address the specific issues of service delivery in rural areas such as emergency oncology care. Also, to be able to provide oncology services in our smaller rural district hospitals is vital. Towns like Cowra, Cooma and Denali, where I was recently, people there, their lives have been transformed by the ability not to have to travel 3 or 4 hours away for cancer services. And I was just talking to Sanchia before I came up about your visit out to Burke, where it's the thought of having to travel 5 hours to Dubbo for cancer services, and still many of those women out there are travelling 5 hours to Dubbo for maternity services. So there's real challenges in so many of the areas of health in remote New South Wales in particular. I'm very pleased to learn that today's proceedings will close with a panel discussion that equity does not mean treating everyone the same. The New South Wales Government is committed to ensuring that people have access to cancer services close to where they live, if at all possible. The time, effort and cost of travelling long distances to receive cancer treatment are all significant barriers for people who live outside metropolitan areas. However, not all services can be delivered locally, and the New South Wales Government is also committed to ensuring patients and their families who need to travel because of the rarity of their cancer or the complexity of their care will have care that is well coordinated and with as little cost as possible. And this is a really exciting figure that has become relevant since the opening of the Northwest Cancer Centre out at Tamworth. I think people that have worked in this space over the past 20 years should be incredibly proud to know that 20 years ago we didn't have any cancer radiation oncology services of that type in regional New South Wales, and Wagga started the fundraising. They raised $4.5 million in that community 20 odd years ago, and they were the first to have radiation services out of Wagga. We now have radiation services throughout 6 communities in regional New South Wales, and that has given us a statistic now that 95% of all people living in New South Wales are 100 kilometres are within 100 kilometres of cancer therapy services. I'm extremely proud of our talented and dedicated health professionals, and I appreciate their commitment to lessening the impact of cancer on the people of this state. I take great pleasure in officially opening the conference today, and good luck with your talks, your deliberations and your learning and your sharing. It's a wonderful initiative, and I hope it continues on to next year. Thank you very much, David.
Good morning, everyone. I'd just like to offer some thanks to the Honourable Melinda Pavey for her words of opening. They've really covered the spectrum of what we're here to talk about today, and it's great to be working in a government environment that has such commitment to cancer services and in particular to the health of regional New South Wales people. So it's my pleasure to welcome you also all here today, and I'd like to just start with offering a couple of thanks to the people who've really made this possible within the team in Cancer Services and Information at the Institute. It's always dangerous to single anyone out because there has been a lot of people, but I'd particularly like to offer thanks to Catherine Bullivant and Emily Potts, who are the logistics team behind this event, following on very closely from the Premier's Awards for cancer research only a couple of weeks ago. They've really had a great lot of work to do in a very short space of time. So thanks, ladies, and all your helpers. So it's my pleasure this morning to introduce firstly Professor Jon Emery to provide our keynote presentation on integrating primary care and cancer services. How can we be more innovative? Jon, as has already been described, as the Winthrop Professor of General Practice at the University of Western Australia, a position he migrated to from the University of Cambridge, and we are very pleased that he chose to come to Australia. He's the director also of the Australian Primary Care Collaborative Clinical Trials Group, affectionately known as PC4, and really building a program of research to build the evidence base for cancer care in the primary care sector. He's recently been appointed to the chair of primary care cancer research at the University of Melbourne as part of the Victorian Comprehensive Cancer Centre, and that brings him excitingly to the East Coast, where we can draw on his skills much more. He studied medicine at Cambridge and Oxford and obtained his Doctor of Philosophy at Oxford on computer decision support to assist cancer risk in general practice. His specific research interests are in the role of primary care in cancer diagnosis and management, complex interventions, genetic medicine, and primary care trials. And much of his research entails parallel programs of work on cancer screening, diagnosis, and follow-up in both Australia and Cambridge, keeping the work internationally connected. He has over 100 peer-reviewed publications in the last 12 years and been chief investigator on many research grants, totalling 11 million Great British pounds and 16 million Australian dollars, including more than 13 million in competitive NH and MRC and Australian government grants since arriving in Australia. So he's very well positioned to talk to us today on the topic of integrating primary care and cancer services. Welcome, Jon.
Thank you very much, Sancha, for that welcome, and thank you very much for inviting me here to this Innovations Conference. It's a very interesting conference to be part of, and again, very grateful for the invitation. So let me just work out the technology. There we go. Okay. So I'm going to be presenting the results of a rapid review that the New South Wales Cancer Institute commissioned PC4 to conduct towards the end of last year, really looking at the evidence for the role of primary care in both early detection and follow-up. And so I'm going to be presenting the results of that rapid review, covering screening, early diagnosis, follow-up and survivorship. And some of the recommendations that we specifically presented to the Cancer Institute of New South Wales in terms of potential service developments and recommendations for research. To begin with, though, I just wanted to set the context for the review, and also just to get everybody in the same space of where primary care actually sits across the cancer continuum. So, I'm hoping, yep, good. So essentially, primary care, we see patients at all points along the journey, and we have a role across all of them. And so if we start here in the sort of pre-cancer phase, primary care has a very important role in primary prevention in terms of lifestyle advice and management, risk assessment and identifying people and families who are at potentially increased risk of cancer. We have a very significant role in symptomatic detection and also in screening, cancer screening programs. So that is a major function of what we do. Although at an individual general practice level we may see relatively few new cancer diagnoses, so on average a GP would see about 6 to 7 people with a new diagnosis of cancer each year, we see an awful lot of people who may be concerned about symptoms or symptoms that may be suggestive of cancer. And so that's a major part of what we do, is trying to identify those people who may have cancer and require further investigation. Once somebody has been referred on and a diagnosis has been made, they obviously go into their acute cancer treatment, and this is at a time when general practice often feels rather detached from the process. We may receive information from time to time about what's happening, but we often feel somewhat removed from that point in our patient's journey. After treatment, though, there's a growing recognition that primary care does have a role in some way in survivorship. We certainly know that patients after a diagnosis of cancer present to their GP more frequently than before. But there's a growing recognition that we may actually have a more systematic way of becoming involved in survivorship care. And then obviously for some, for some people who move into the palliative care phase, again there's a growing role for palliative care and shared care models of palliative care that involve primary care. So those are the sort of various aspects that we can become involved in. But there are some important sort of cross-cutting themes. The first is around risk assessment. And so in the prevention space, obviously it's identifying people who may be at increased risk and who might require additional screening or preventive measures. In terms of symptomatic diagnosis, it's identifying the risk of an underlying cancer. And then in terms of survivorship, there's a growing recognition that we may be starting to think about more risk-stratified approaches to cancer survivorship. So who are the people who can potentially be safely followed up in primary care and actually remove some of the burden of follow-up on very busy oncology services? The second area is around care planning. Again, this is a core element of what we do in primary care in terms of coordinating care for our patients. And so, again, this is a key cross-cutting theme across the cancer continuum. And then finally, essentially, the reason that we have primary care is in a health system is the very strong evidence, particularly from people like Barbara Starfield, that a very strong primary care system is what contributes to a cost-effective healthcare system. And so this is all about actually delivering timely care at the right point in the healthcare system. Okay. So this is the rapid review that we were invited to conduct by the New South Wales Cancer Institute, and it's now been published. And I'd just like to acknowledge my co-authors. I'm very pleased to see that Lyndall Trevena is in the audience here today. And so this was a piece of work that PC4 conducted last year. And as you can see, we were asked to focus very much on the role of primary and community-based healthcare in early detection and follow-up of cancer. And we essentially reviewed the highest quality of evidence that existed. So we looked predominantly for systematic reviews where they existed, or randomized controlled trials, or if neither of those levels of evidence was available, then we looked for very large-scale observational studies. And we were asked to make recommendations about future service developments and future research. So I'm going to talk you through these various components, mapping it back onto the cancer continuum. So first of all, we looked at the role of primary care in cancer screening. We obviously have 3 national screening programs now for cervical, breast and colorectal cancer. And so what is the evidence around the role of primary care in increasing uptake of cancer screening tests? Well, there's actually a lot of work being done in this area. There are 5 systematic reviews that covered this topic. This is the first type of intervention that's been shown very clearly to be effective, so audit and feedback. So this is about going into an individual practice, auditing their records to identify which people are up to date with their various cancer screening tests, and then providing feedback to the practice on the level of screening uptake in their practice, identifying approaches to improving that, and then completing the loop and repeating that audit after you've made some implementation to improve uptake. And so this, again, is very strong evidence to suggest that this is an effective way to increase uptake of cancer screening through primary care. The second is around what are called office symptom prompts. So most GPs are now computerized. Some of the very early studies were based on paper-based prompts where you actually stuck a little flag on the paper records. But now this is a much easier thing to do. And so this is a way of electronically prompting the GP when a patient comes to see them that their patient is actually due a particular screening test. And again, very good evidence for really large increases, but mainly in mammography and cervical screening, that this type of prompting approach for GPs to be reminded that actually a person requires screening at that point will increase uptake. And then the third area, which is really being studied, particularly in the area of colorectal cancer screening, is in the role of GP endorsement of screening invitations. So this is the idea that before a patient receives their actual invitation from the screening program, a GP letter comes to them in advance saying that you're about to be invited to have a screening test, and this is something that we recommend that you actually consider and participate in. And so there's been a number of trials, and several recent trials, including some conducted in South Australia, that have shown that a letter from a GP prior to receiving, for example, your FOBT test in the mail will increase uptake of that test. And then there's the bigger picture of actually trying to implement within a practice a whole system change. And this is really about implementing some of these different components that we have separately been shown to work. And so this involves really a practice taking on board the evidence that we know about setting up patient and doctor reminder systems, patient education, and potentially endorsement letters as well. And if you take on this larger practice organisational change, again, this can have large impacts on uptake of cancer screening tests. So there's a lot that can be done in primary care, but it does require some systematic thinking at the practice level. And so these are some of our recommendations to the Cancer Institute of New South Wales. Firstly, that they work with Medicare locals to develop a program where they actually support practices to implement these types of organisational change. And so the types of change that we would be looking to implement are the ones that are very strongly evidence-based. So setting up a mechanism that, for example, when you know that your patients are turning 50, that you send out a letter 2 or 3 weeks in advance saying that you're going to be receiving your FOBT kit, and we suggest that you seriously consider that invitation to participate. Setting up recall and reminder systems, providing feedback to the practices on an ongoing basis about their local screening uptake. And the one area that, there was one study that showed that setting up a specific cancer prevention clinic within the practice, so you invite people to actually come in and talk about their cancer risk and devise specific strategies and, for what screening they require. There's strong evidence from this, just one single study, that this actually can have a very large impact on appropriate screening. So those are the areas that we recommended. Interestingly, you probably can't read this very well, but this is the letter that went out to GPs from the National Bowel Cancer Screening Programme in June this year, with a whole series of recommendations to practices about the sorts of things that they could be considering to improve their participation in the bowel cancer screening programme. And this includes, for example, the things that we have talked about, setting up audit and feedback systems, thinking about sending out letters to your practice patients at the time that they are due to receive one of the kits. At the moment, this was just sent out in the mail. I think this is just the very first part of what needs to be a much bigger implementation strategy. GPs will have received this, they may have read it, but without a lot more input into the practice, it's unlikely that they're going to take up some of these recommendations. And again, I think this is where working with the Medicare locals and actually having Medicare local staff who are going out to the practices and supporting practices to implement some of these organisational changes is what's really required if we're serious about trying to increase the uptake of various proven cancer screening tests. So I'm going to move on now from screening to the area of symptomatic diagnosis. And so again, there have been various different interventions that have been looked at and the most important one, and I think the most interesting one, is around fast-track referral pathways. There have been a number of smaller studies, again, that have looked at audit and feedback, decision support systems, the role of just broader GP education, and then risk scoring systems, which again is an area I'm going to talk about in more detail. So fast-track referral routes to begin with. So what this means essentially is the idea that you identify people who are, based on their symptom profile, are considered to be at sufficiently high risk of an undiagnosed cancer that they warrant urgent referral into the hospital system for a diagnostic workup. The largest example of this was the 2-week wait system that was implemented across England back in the early 2000s. And this was a major system change and of setting up these 2-week wait clinics across all hospitals for multiple different cancer types. It required the implementation of urgent referral proformas, so the only way you could access these 2-week clinics was if you referred your patient on one of the referral proformas. They had dedicated fax lines so that you could only, again, refer through this particular route. And what they were doing, essentially through these referral proformas, was implementing the guidelines through, that were outlined through this NICE document. So what NICE had done was look at the evidence that was available at that time, at the symptoms, specific symptoms and combinations of symptoms that were highly suggestive of an undiagnosed cancer across multiple different cancer sites. And so the fast-track referral route model and all these system changes were really about implementing these NICE guidelines for referrals for suspected cancer. That model has been in place for several years now, and so we've now actually got really quite large observational data about the impact of this major policy change. And there are really two important metrics about that measure the utility of this approach. The first is the conversion rate. So this is, if you look at all the referrals that were channeled through this fast-track route, what proportion of them actually ended up with a cancer diagnosis? And then the second is the detection rate. So this is of all the cancers that were ultimately diagnosed, what proportion were actually identified as suspicious enough to channel them through that fast-track route. So those are two really important metrics to think about in the context of fast-track routes. And so again, there were an awful lot of audits that were conducted, usually at individual hospital levels, to look at the impact of these fast-track routes once they'd been implemented for some time. And so there's been this systematic review of audits of the 2-week wait system. It's difficult to some extent to know exactly what to make of this systematic review because there was a huge variation in their findings. In terms of detection rate, so between 0 and 57% of lung cancers across various studies were detected through the fast-track route, and similarly conversion rates with lung cancer between 0 and 75% conversion rates. What was interesting is actually that the GPs, perhaps unusually, conform very well to guidelines. Most of the time we're not very good at following guidelines. What made a difference was this major implementation strategy where you had to, if you wanted to use this route, you had to use the referral proforma, and that required you to specifically state which of the symptoms that mapped onto the NICE guidelines that you were concerned about. So it just shows that if you do have a strong implementation strategy, GPs are actually quite good at following guidelines. There's a second systematic review that looked specifically at 2-week wait referrals for colorectal cancer, and they came up with these summary figures of a conversion rate of 10%, so 1 in 10 referrals for urgent colorectal cancer clinic were actually cases of colorectal cancer. And a detection rate of only 24%, which so 3/4 of colorectal cancers were actually diagnosed through some other route, and 24% of those were through emergency admissions. Since then, there's been an even larger national audit published by David Meakin and Greg Rubin that have collected all the national data and compiled it, looking at it at individual practice level. And so their summary conversion rates were 11%. So this is across all the different cancers. So now you could argue that conversion rate of 11% doesn't sound very good. I actually think this just reflects how challenging this is for primary care. These are undifferentiated patients. And the symptomatology of cancer overlaps very strongly with a lot of benign conditions. This is a difficult thing for us to do well, and so a conversion rate of 11% is actually pretty good. And a detection rate of 43% I actually think is again pretty good. So you're detecting nearly half of all the cancers and channeling through this fast-track route. However, there's very large inter-practice variation. This is unfortunately a common factor of general practice. We're very heterogeneous as a discipline. There are some practices that performed much better using these 2-week referral routes than others, and that's what this diagram is essentially showing. So on the x-axis we have the conversion rate, and up here is the detection rate. And each white dot represents the performance of an individual general practice within England. And as you can see, there's quite a wide scatter of conversion to detection rates. Not surprisingly, there's a correlation between the two. And so practices up here are performing really very well. They're getting quite a high conversion rate, but also a pretty high detection rate. Down here, practices are performing much poorer. Their detection rate is poor, so the majority of their cancers are not being channeled through the 2-week wait, but also their conversion rate's very low too. The practices up here, performing best, have a conversion rate of about 14%. That's probably as good as you can get. And a detection rate of about 50%. So they're picking up about half the cancers through the fast-track route. And so this, I think this is the best evidence that we have around the role of fast-track routes and a recognition of actually the challenges of early diagnosis of people with symptoms in primary care. This is some data that Richard Neal, who's a colleague of mine from North Wales, and again, they have been looking at this at an individual tumour level, because some cancers, not surprisingly, are harder to detect earlier than others. And so these figures are showing the changes in the diagnostic interval, so the length of time to diagnose particular cancers before and after the introduction of the 2-week wait system within the UK. And the ones that are highlighted are the ones where there has been significant reduction. So colorectal cancer has done pretty well. There's been a reduction in 20 days. Pancreatic cancer, a small reduction, but that still actually was a significant reduction. Esophageal cancer again, kidney and bladder. So these are the ones where the 2-week wait system seems to have had a larger effect. The disappointing ones are lung. Really no change since the introduction of the 2-week wait. And really that's one of the most challenging ones that we're trying to improve in terms of early detection. Breast was already doing very well anyway. So I think what this goes to show is that there are some cancers where there's greater potential to have an impact on time to diagnosis through this fast-track route than other cancers where we need to be thinking about maybe other strategies. And this all comes back to the epidemiology of cancer symptoms in primary care. When the NICE guidelines that were underlying this fast-track process were introduced, there was actually very limited evidence on how well symptoms, that as they are seen in primary care, predict an underlying diagnosis of cancer. Most of the research at that time had been based on referred populations, where GPs have already sieved out a lot of people with symptoms anyway. And so what that means is that in those referred populations, you tend to overestimate the predictive value of symptoms. But since then, there's been some really interesting work based on very large general practice databases, particularly by two researchers, Willie Hamilton and Julia Hippersley Cox. And I'm just going to talk briefly about these pieces of work. So these are studies that have looked at large general practice databases, the presentation of symptoms in primary care, and subsequent diagnoses of cancer, so that you can get a much better estimate of how predictive symptoms are as they present in general practice to a diagnosis of cancer. So this is one of the charts that Willie Hamilton's work produced. And again, I'm going to just talk through this. So up here we have various symptoms, physical signs, and also results of investigations. And the top figure in each of these is the positive predictive value. So the probability of an underlying cancer diagnosis, so in this case colorectal cancer, in the presence of a single symptom or sign. So as you can see, for a single symptom, even rectal bleeding, you've only got a 2.4% chance of having an underlying colorectal cancer. Then if you look at combinations of symptoms, if you have two separate episodes of rectal bleeding, it goes up to 6.8%. The value of anemia is perhaps not that surprising. So if you have abdominal pain and a low hemoglobin, again, that puts you up to 6.9%. The red ones essentially all represent the combinations of symptoms above a PPV of 5%. So this is a way of starting to get an evidence base about how well individual symptoms, combinations of symptoms, actually predict the risk of an underlying cancer. Willie Hamilton has produced these for a range of different cancers. He's slowly just ticking them off. And so these charts exist for a very wide range of the common cancers now. Julia Hippersley Cox has gone, to some extent, one step further with this model, again based on very large GP data sets. And so what they have done is produce a rather more sophisticated regression model that takes account of both, takes account of your age, your baseline risk factors, your family history, and then a whole load of different symptoms. And then it comes up, not with a single risk of cancer, it comes up with a risk of a whole load of different cancers based on your symptom profile. And so in this particular instance, you can see that your overall risk of having no cancer is 92.5%. But then these are the specific cancers. So it gives you an idea of the hit list, really, which are the most likely cancers that you need to be thinking about and therefore investigating for. I don't like this bit, of course, but I think that's a rather poor way of presenting this risk. But it gives you an idea that we now have quite sophisticated risk models based on primary care data that allow GPs to think much more systematically and scientifically about the underlying risk of a range of different common cancers. So to summarise the data on that we identified, fast-track routes, I think, can reduce the diagnostic intervals, particularly in health systems where there are long waiting lists for diagnostic services. And this was particularly the case in the NHS, and I think is also true in many of the public hospital systems across Australia. We have long waiting times for particular diagnostic services. Fast-track routes aren't a panacea. As you can see, there are variations in the way GPs apply them. It's not going to mean that every referral is definitely a cancer, because it's just much harder than that. And so we need to understand a bit more about GP variation. But if you're going to do it, it's not just about sending out some guidelines to general practice. This needs a major restructure at the hospital end and also a major implementation strategy at the GP end to actually implement this process. It will be more complicated to do in an Australian setting where we have the muddied public-private split of services. So I think if we were to think about the context of doing this in Australia, it would require a recognising the additional complexity of the system in which we work here. I haven't had time to go into this, but there's also additional evidence that audit and feedback around your referrals and multifaceted interventions that include education, audit and feedback can also improve the diagnostic capacity of GPs to accurately diagnose cancer early. And I think there's an interest and a further research at least to look at the role of these CAPER and Q-cancer models to see whether it actually can support GPs to pick those patients who require urgent investigation more effectively than our current sort of heuristic way of thinking. So we are doing some of this work already in WA. Within we're conducting a large rural cancer project at the moment called the ERCO project. And within that, at the general practice level, we are trying to implement some of these CAPER risk charts. So for lung, prostate and colorectal cancer, and also the NBOC guidelines around breast cancer. And we're trying to implement both these risk charts and also the best referral routes in to access diagnostic services for these different cancers. And so the ERCO trial is actually testing two different levels of intervention. One is at the community level. So we're testing within the red areas in this map of WA, a community symptom awareness campaign based on some previous work that we have conducted showing that lower symptom awareness and delays in presentation due to issues around symptom appraisal and later help seeking in the rural population, and particularly around the role of stoicism in the rural population that may contribute to later presentation. And so we're conducting a symptom awareness campaign in these trial area A's, alongside working very closely with the Cancer Council of WA. And then, as I say, at the practice level, we are implementing these risk charts, the CAPER charts, through multiple academic detailing visits through general practices within a cluster randomised trial. And so it's a 2-by-2 factorial trial, and we're interested in whether or not this will reduce the time from first symptom within the patient to actual diagnosis of cancer. So the total diagnostic interval is our primary outcome. And then we're also just beginning to develop some work on Q-cancer, so modifying it so it's got a slightly simpler interface, and starting to do some very early exploratory work with GPs to get their feel for whether or not this is a tool that they could see as potentially useful, and how they might interpret some of the outputs from it. So again, this is just very early toe in the water, exploring whether there is a potential role for these types of tool and how GPs might actually use them. So again, going back to what we recommended to the Cancer Institute, we recommend they work with Medicare locals again and local hospital networks to define much clearer referral routes for patients with a high suspicion of cancer. And considering a phased establishment of fast-track referral routes within the public healthcare system, commencing with colorectal and lung cancer, though this was before we actually received the data from Richard Neal, I think colorectal cancer there's a very strong evidence for. It's interesting that lung cancer time to diagnosis hasn't changed at all in the UK despite their fast-track routes. And so we may need to rethink again about what we do with lung cancer. I think there's further work to be done around Q-cancer and CAPER. And the other thing is NICE are currently revising their guidelines, and based on so much of the primary care data that has now arisen that wasn't available to them at the time when they were first developed. And so I think we need to keep a close eye on what those revised guidelines look like as well, if we were thinking about implementing some sort of pilot fast-track route for one of these cancers. Yes, as I said before, if you're going to do it though, it requires a major investment. This is a major system change that you need to implement if it's actually going to work properly. And if you are going to do it, you need to collect data to show whether it's made a difference. And so this is the importance of setting up very good data collection processes so that you can actually perform those large-scale audits that I presented to see what effect it's actually had on conversion and detection rates. So that's the pre-diagnosis end. I'm going to move now on to follow-up and survivorship. Again, there's a lot of research that's been conducted in this space. So we've got 6 systematic reviews, 2 additional RCTs, covering these various aspects of primary care and their role in cancer follow-up. So first of all, I'm going to just present summary findings of where they've conducted trials where you've replaced entirely hospital-based follow-up with primary care-based follow-up. And interestingly, in the systematic reviews of those trials, there's absolutely no differences in any outcome, no difference in patient well-being, recurrence rates, survival, diagnostic delay, or patient satisfaction. And the one health economic evaluation of one of Eva Grunfeld's earlier trials in breast cancer showed that it was cheaper than hospital follow-up. Again, though, most of the evidence in this particular area is in breast cancer, and predominantly the work of Eva Grunfeld in the UK, and then subsequently some large trials conducted in Canada. Then we looked at shared care models. And so there have been various models that have been tested where you have varying degrees of sharing of responsibility between the hospital and primary care. There are some core elements to it, so structured discharge letters, some form of educational package, and very clear contact routes and referral routes back to the specialist service if needed. And actually the evidence for these is quite strong in the sense that patients and providers were more satisfied. It increased providers' confidence to deliver care, and there were suggestions that patients, once they'd experienced this shared care model, actually preferred it. Then we looked specifically at the role of patient-held records. There's been a lot of money invested around the world of developing some form of patient-held record, usually a paper-based. They've trialled various formats, and they're all with the assumption that this is going to improve the major challenge that we have of communication between the two sectors. So it's about improving both patient involvement, but more fundamentally, the usual issue is about trying to improve communication between the hospital and the primary care provider. The evidence is mixed. Some patients like them. Some patients didn't actually find them very useful at all. Most primary care providers like the idea of them. Unfortunately, no, they had no benefit on communication, no changes in quality of life, and no changes in patient satisfaction with care. And the main reason is that doctors just don't use them. They don't fill them in. And it's an extra thing to do. It's an extra task when they've already got the hospital record to complete or the GP record to complete. And so they just remain empty or very half-used. And so this is a major problem. And I actually think that we can be pretty clear that we shouldn't be continuing to go down this route of a paper-based patient-held record, because I think we've now got very good evidence that actually it's not worth investing resources in. Survivorship care plans, all the rage. ASCO recommend them as standard practice. There's actually only been one trial within primary care of the role of survivorship care plan in a model of primary care follow-up. Again, Eva Grunfeld led this. It was a trial of, again, women who'd been discharged into primary care follow-up, and at that point the GP received a survivorship care plan. So this was a trial of 408 women after breast cancer diagnosis, but some of them had actually been diagnosed several years on, so there were a lot of prevalent cases. So a large proportion of these women were women who'd been diagnosed more than 3 years previously. The trial, I think disappointingly for many people, because I think they were expecting positive results in this trial, found no differences in cancer distress measured on the impact of event scale or general distress, and no differences in continuity of care or patient satisfaction. There are a lot of methodological issues around this trial, and I think we should just treat this as the very first trial of looking at this. I think there are issues around the population that they applied it in. I think really you need to be looking at patients very recently completing treatment and being discharged into primary care, because I think there may be a much better role for them at that time point. So I think the jury's out, and there are more trials obviously in progress. We're currently conducting one in prostate cancer, the ProCare trial, where the survivorship care plan is a core component of a complex intervention to support shared care. So the summary of our findings, so both primary care and shared care models have pretty much equivalent outcomes to hospital care, but the strongest evidence for this is really in breast and colorectal cancer. It's important, though, to recognise that both patient and provider preferences varied quite a lot within studies, between studies, and between countries where these models have been tried out. But once patients have experienced a model where there's primary care involvement, then their support and satisfaction for it tends to increase. There are a number of studies that have interviewed, for example, cancer patients, just saying, what do you think it would be like if your GP followed you up? And in a lot of those, they say, oh, I don't think the GP could do that, and so on. I really don't think they're skilled to do that. But actually, if you then look at studies where, in the trials where people have actually experienced it, then actually those attitudes towards primary care follow-up change. So again, I think we have to be careful about interpreting some of those early studies that just talk about attitudes without experience involved. The thing is, though, if primary care is going to take on this role, there's some very core elements that need to be part of a shared care or primary care-led model. GPs need very clear guidelines about their role and what is expected of them. Very good communication with the hospital, and a very clear route of access back to specialist care. So those are the core ingredients to making this work. So it's not just a matter of sending a letter, discharging and cheerio, or forget about you. These are the really core things that we need to get right if some sort of shared care or primary care-led model is going to work. So again, these are our recommendations. So we recommended the development of new models of follow-up initially for breast and colorectal cancer. And I know quite a lot of work is already occurring in this space. That if you're going to do this, then there needs to be very clear guidance for both patients, primary care and cancer professionals about treatment and follow-up plans. So a very explicit follow-up plan with specific tailored advice about the management of adverse effects of treatment, and very clear mechanisms for rapid referral back to the specialist if required. The other key bit is thinking about patients shortly after completion of treatment. They need to re-engage with their GP, and so we recommend that at the point of completion of treatment that there's strong emphasis made that the patients go back to their GP, coinciding hopefully with the delivery of very good information to their GP about what has been happening to their patient. Then there's the role of the electronic health record. We know paper shared records don't work. We have to be thinking, though, about how we can make the best of some form of shared electronic health record to improve communication that doesn't require duplication of effort, but actually requires that seamless sharing of information across the healthcare system. This is a big task and a big challenge. The current federal PECHR is still very much in its early phases of development, but I do think we need to keep this high up as a priority for how we actually can implement shared care models that depend on a very good shared electronic record. I think we also have to recognise that there's a need for flexibility, that not all patients will want to do this, not all GPs will want to do this as well. And so there has to be some approach to considering patient and provider preferences at an individual level in determining appropriate follow-up care. And then the other interesting areas around how you stratify which cancer patients are safe and appropriate to follow up in primary care. The current Macmillan model in the UK recognises risk stratification as a really key part to developing a more cost-effective approach to survivorship care. But the detail of how you do this stratification is still really being worked on. It shouldn't be just about risk of recurrence. It's got to be. It also has to include current unmet needs of patients as well. And so the details about how you start to implement a more risk-stratified approach to follow-up really needs further work. I think we also need to be looking at models of long-term cancer survivorship, particularly thinking about the broader health needs of patients after their cancer treatment and several years after their cancer diagnosis. Many of them will have comorbidities. Oops, slightly worrying. This is telling me I've had enough time, is it? We need to think about the issues for longer-term cancer survivors, particularly the late effects of some of the cancer treatments, and ensuring that they're not forgotten about. And also that there was some evidence from there was one systematic review that had looked at a number of observational studies of longer-term cancer survivors, and a suggestion that while their cancer needs and their cancer screening needs are well met, the management of their other comorbidities may be slightly ignored, and we have to think very carefully that you don't just think about this person as a cancer survivor. They often have other medical needs as well, and that's what good general practice is all about. And so it's about that overall holistic care of longer-term cancer survivors. And then we need to be thinking about the health economics of these different models. And actually, if we are going to be testing new models, we've got to have a health economic evaluation embedded within those research studies. So that's a summary of our review and some of the major recommendations coming from it. I think our hope is that some of these will influence policy both within New South Wales and elsewhere within Australia. One always hopes as a researcher that policymakers at least take note of the existing evidence, although it's not always easy to implement that evidence at times. The detail is available on the Sachs Institute website for those who are actually interested in obtaining this review, and we'd very much welcome any feedback and thoughts on how applicable some of the findings and some of the recommendations may be, both within New South Wales or elsewhere that you may work within this country. Thank you very much.
So we have time for some questions for Jon. There's some microphones at the front if anyone's brave enough to make use of them. While we're waiting, Jon, I wonder if there's anything in the evidence around the characteristics of a primary care provider or setting that could help judge whether or not follow-up models or even care during treatment could be assessed in terms of the suitability?
Yeah, look, that's a great question. We didn't find anything that would allow you to identify, which practices are more innovative. I mean, there's a whole body of work around primary care and how you implement new service models within the primary care sector. Trying to tease that out is very detailed. There are a number of theories that can help inform how you might identify which practices are more open to change. There's a lot of theories around how you do this and how you understand the detailed processes of implementation. But there's no simple answer. That's another whole talk.
Yes, it is another whole, but it makes for, thinking about risk stratification of patients, you're also thinking about what's the environment.
Absolutely. But I think to some extent that's why it's really important that if you are thinking about alternative models of follow-up, you have to recognise that your patient hopefully they have a relationship with their GP, not all of them will, and some of them will have much greater trust in their GP in the capacity to do this. And similarly, some GPs will be much more open as long as they can be assured that they will be provided with the clear information that they need to deliver this care. And that's certainly what we're finding in the ProCare trial. We've got about 90% agreement of GPs to take on this role within the shared care prostate cancer follow-up. The ones who turn it down are the two main reasons are. One, it's a research project and they're just not interested in anything that's got research involved. And the second is there are some who just say, look, I can't take anything else on. But I think it's reassuring that 90% of them, if you tell them actually what the study's about and that they will be provided with the information and support they need, think, oh yeah, I can do this.
Excellent. Tim Shaw.
Hi, Tim.
I don't think it was in your brief, but it's kind of the role of multidisciplinary teams. I know it's a vexed question between primary care and the role of primary care and multidisciplinary teams, but is there any evidence around this about how the multidisciplinary team can actually be facilitating this communication, referral, diagnosis, and so on? Obviously, there's Can Refer here, which is a tool that the Institute's built, but any thoughts on that?
Yes, it's interesting. We didn't come across specific evidence around that, although we didn't specifically look at the role of the MDT. There have been some studies that have tried to increase the involvement of the GP at those MDT discussions, and the feasibility of doing that is just very challenging. I think the precise role of the MDT at different stages in the whole cancer journey, I think, is still open for discussion, where they fit in terms of the diagnostic workup. And so is it still appropriate? So, one option is that we have certainly been thinking about within our rural project, is that we very much strongly promote referral routes into providers that have a very clear link to an MDT. And I know that's some of the work that's going on in New South Wales as well. So recognising that patients are more likely to get better assessed if you've got a provider that is linked into an MDT. So I think we can be trying to promote that, although, of course, that's in an evidence-free zone. It's just good consensus opinion, really. And then there's the role of the MDT at the other end in ensuring very good communication back out to the GP at the time of treatment decisions, and ensuring that the GP knows about what options are being discussed, so that their patient might just come and want to talk to them about it.
Good. Last question from Richard.
John, in terms of survivorship follow-up, do you have any thoughts as to how information on the survivors would be fed back for research purposes to the care teams?
In terms of, so you're concerned that they may be lost to follow-up from a research point of view?
I think there is that risk.
Yeah. I think that is an important point, and particularly for longer-term follow-up, which I know in your area you'd be particularly concerned about. And especially as we don't have a model of any form of patient registration to a practice. There are significant risks about how you ensure a maintenance of a link back into the hospital and for those research purposes. My feeling is that it may actually be better to still try and maintain that link directly through the patient rather than through their GP, because patients change GPs, and it's more about how you try and maintain a register of your patients, even if you're not necessarily seeing them for follow-up, rather than relying on trying to track down which GP they're seeing as they move around the country. Yeah.
Excellent. Well, please join me in thanking John. He'll be with us all day, and just get to catch up with him. So So it's my pleasure now to introduce our second keynote speaker, Associate Professor Sabesan, who's the Director of the Department of Medical Oncology of the Townsville Cancer Centre at Townsville Hospital and the Clinical Dean of the Townsville Clinical School for James Cook University. Sabe obtained his medical degree from Flinders University and has worked a lot in rural Australia, both at the Alice Springs Hospital. He's done some city-based work at North Shore in Sydney and Royal Brisbane Hospitals before settling in Townsville. As has already been mentioned, he's established a large telehealth network in North Queensland. The 750,000 square kilometres is a guess. I'm sure he's talked across most of it, but he is providing a comprehensive medical oncology service to 19 rural centres and has been doing this since 2007. He's also a member of the Cancer Council Australia's National Guideline Writing Committee for the Management of Advanced Prostate Cancer and Melanoma, as well as the Oncology Education Committee and the Royal Australian College of Physicians Telehealth Working Party. His research interests include rural and Indigenous cancer service delivery and specifically the use of teleoncology and cancer education. We're delighted to have him with us today to talk about telehealth in cancer care, current status and future directions. Thank you, Sabe.
Thanks for that introduction, and thank you, Cancer Institute New South Wales, to invite a Queenslander to share the views on innovations. And I'm delighted that my heart is syncing with this innovation concept, so I'll share a bit more and see what we can do at national level rather than health service districts levels. So I'm really passionate about, whenever I give this talk and people say, oh, you're really passionate about telemedicine and telehealth, it's really, my passion is in the rural, Indigenous and regional health. And telehealth is really a tool for improving services. So I'm interested in telehealth, but my passion is actually in the issues and the solutions. So I was fortunate enough to go through Central Australia and had lots of country friends when I was at Flinders to experience the issue of rural, regional and Indigenous health in Australia. So this slide really tells you the story of a rural patient. So if you look at rural patients in the center, they travel to tertiary care for standard practice as well as clinical trials. They go to their GPs in rural towns, they go to local hospitals when they are sick. And in the mix of things, there is specialist travel from tertiary hospitals to rural towns. The whole day is wasted on that. And there is patient and specialist travel from tertiary hospitals to local hospitals. And there's inter-hospital transfers whenever people are sick. There's a lot of human hours wasted in these journeys. And also when patients travel to tertiary centers, there's issues of distance, cost, and the relocations. And the rural sector has its own issues. There's ongoing workforce shortages, skill issues, training and supervision, resources and specialist support. So if you look at it in another angle, and if you think the access to specialist services in rural and remote areas is the main issues, what I saw in the last 10 years was a vicious cycle developing. Oh, it's not developing, it's actually already there. So if you start with limited specialist services as one of the issues, access in rural towns, and because of that, people have to travel to even see a specialist, not just getting treatment, just to see one. And because there's not much specialist services and the scope of practice remains narrow in rural areas, so the nurses and doctors continue to do what they've been doing for many years. And because the activities are limited. It's very hard to get any business cases going to improve your workforce. And if you don't have enough workforce, then the specialist services continue to be limited. So it's a vicious cycle. The end outcome is that people continue to travel. And this is where I saw the benefit of telemedicine and thought telemedicine can immediately address this. So if you get a specialist to see patients, it's actually not just for cancer, for anything. And then that alone will cut down your travels. And if the specialist and the nurses suddenly decide, okay, they can do some sort of treatment, then the scope of practice can improve. That will again, by doing two simple things, it will cut down the travel again. But then if you become fancy and gutsy and you're doing more things, and then that's when you'll be successful in getting business cases for increasing workforce numbers, and that automatically gives you a virtuous cycle, and the benefits are endless. So this is where we started in 2007 in Townsville Health Service District. That goes from Townsville there all the way across the border. That's about 1,200 kilometers. Beautiful drive, red rocks, ghost gum trees and dry riverbeds and cattle to negotiate with. And it's really a great holiday because no one can even reach you on your mobiles. So we started initially with Townsville and then between Mount Isa and Townsville. So we have a medical oncologist. Now it's actually the radiation oncologist also jumped on board with the palliative care hematology. So we have our specialist staff. We have our tele-oncology coordinators. And then in Mount Isa, now we have rural-based doctors, chemo nurses, allied health coordinators. So we see patients like that. And all of the small towns, we just want to keep spreading like cane toads across the state. So what also now happening is that we have in the small towns, it's very difficult to do chemotherapy. So we have a policy now that all the new referrals from rural towns have to be seen on Telelink, not just for seeing patients, also for triaging, so that the future care is coordinated better. So immediately here, we have primary care involved from the time of referral. So the GP sits with the patient or the nurses, and we see the patients from Townsville. Just 2 weeks ago, I had a patient from Richmond. That's somewhere here. There's about 600K there. A patient with lung cancer. She was a 75-year-old lady with multiple comorbidities. And a GP rang me and said, I got this patient, what do I do? I said, we'll see the patient first. So when we were seeing this patient, so the GP was there, we were discussing, and the family was also there, not just one escort. And we were discussing the options and decided that she was fit enough for oral never-been, oral chemotherapy. And the GP and ourselves came up with a plan together for how are we going to do it on a weekly basis. So now the patient sees me through video link in Richmond on a 2-weekly basis, and the GP alternates. So we have a shared care model from the beginning of treatment. So this is something Jon will be happy with, because we don't have that vacuum during the treatment phase. So this is just my office. I'm seeing a patient in Mount Isa, 900 kilometers away, discussing a patient's lung cancer. Here there's a lesion on the CT scan and the family, and just examining someone on Sutent and Hanford syndrome. So it's really, the clarity is great, and the models are quite seamless. So around the world, there are many medical models for teleoncology. Teleoncology complementing face-to-face and outreach clinics. That seems to be one of the common practices. And second one is teleoncology replacing face-to-face. And that's the example is Mount Isa Townsville link. Teleoncology reviews for treatment reviews and for follow-ups. There are a few models around. I think Tamworth, Matthew, he is doing all of it, I think. and then multidisciplinary meetings as well. So I'll just go through some of the data we have and summarize while I go through. So this one, a summary of our Townsville Teleoncology Network. In the last 5 years, we have 200 patients, including 30 indigenous patients in more than 1,000 consultations. The last 80 patients were managed solely via video link. So that means we never traveled to Mount Isa and the patients never traveled to Townsville. And that's new as new patients. And one of the things I'm also proud of it, that in Townsville we have a 1 week maximum waiting list for new cases, and we wanted to achieve the same outcome for the rural patient, and now we actually, the rural patient also see us within a week of referral. Because of the confidence over time, now we see patients urgently as well in the rural towns, and especially in Mount Isa. Whenever we see patients urgently and start treatment urgently, we actually avoided inter-hospital transfers. So now we could do ward rounds if my patient is admitted, and we do ward consults to the physicians there, because in Townsville it's about acuity of access. So in Townsville or any other major metropolitan tertiary centers, we are required to give consults within 24 hours of referral to inpatient. So our philosophy is that the rural patient should get the same service, and we are able to provide that through telehealth, and I think anyone can do that. 95 patients were treated with chemotherapy regimens in Mount Isa, which I will come back to that soon. So in this slide, not clear, it's slightly a 12-month-old paper from Rural Health Journal last year. So we have patients from 900 kilometers, 1,200 kilometers, all types of cancer, cancers. And in this table, just to summarize what we could achieve through telehealth models. This is Mount Isa figures. We do TAC, TC, all the colorectal regimens, including BEP, ifosfamide infusions, and methotrexate infusion. It's really when my Brisbane colleagues hear about this, they think we are doing some sort of cowboy stuff out there. But really, one thing I keep emphasizing is that the governance around these telehealth models are so strict that it's actually, it's probably, I feel, that it's safe for me to do this in Mount Isa than in Townsville or in Sydney or Brisbane, because what happens in major metropolitan centers, we rely on our registrars and residents for information. And sometimes the specialists actually don't even see the patient in the clinics, and you trust them and make recommendation based on the corridor conversation. Whereas in this one, I see these people every time. So I feel that I'm actually in much control of this rural situation than my situation in the tertiary sector. So just wanted to, in the next couple of slides, summarize the history of Townsville Teleoncology Network, not just to show what we have done, it's actually to show that the models of care evolved over time, and it does take time, training, resources, and perseverance. So prior to 2007, all patients from rural towns and Mount Isa needed to come to Townsville for reviews, first doses of chemotherapy, and complex regimens. And at that time, we had a couple of ED doctors supervise chemotherapy, simple stuff on goodwill basis. And they had 2 part-time chemocompetent nurses for selected regimens. So one day in 2007, we started talking about telehealth, and I bumped into a little machine, cleared the dust and said, "What is this?" They said it's a VCE machine or something. No one has used it. So we just playing with it, and it's actually dialed into some room in Mount Isa, and it said Mount Isa Palliative Care. So I just rang the ED guy and said, "Can you go to that room and see whether we can talk?" And so he went there, and I saw him, and I said to that ED doctor, "Looks like we can actually see patients." And he said, "Fantastic." So that's actually how we started. 2 days later, we saw our first patient without any. But the thing is, really, that time, it was a little bit of a cowboy stuff, because We didn't have any governance, nothing. You see someone in 2 days. We didn't talk to any bureaucrats because once you start talking, you are blocked. So I thought the best thing to do is do and then tell them later. So that's what I did after 3 months of doing this, and actually told them with patient satisfaction surveys that. So that's the initial period. At that time, obviously, willing specialists in Townsville, we had the technology. Fortunately, Queensland Health invested quite a lot of money on technology and willing rural practitioners. So between 2007 and 9, the governance was, we actually started writing governance because people were asking questions. So that time, patients still had to travel for first reviews and for complex regimens. And because we started the activities, as I said, when you start providing services, the business cases become easier. So we had 2 chemo nurses competing in most regimens. We were able to get a half-time senior medical officer, it's a rural GP, rural generalist, for oncology. So more funding through data, and also Mount Isa had some high-end services. And then in 2009, we reviewed our model again. So now, by these times, slowly increasing our workforce. We had an oncology SMO, we had a rotating RMO, cancer care coordinators, allied health, Aboriginal liaison officers. And we looked at our safety data and realized that patients don't even have to come to Townsville. So that's when our governance changed to replacing face-to-face care with tele-oncology care. So enablers were upskilled rural generalists, tele-oncology coordinators, and more staff at the providing end at the rural end. So what we have now in Mount Isa is a specialist cancer clinic via video conference 3 to 4 times a week and on demand. All new urgent reviews and review cases, all solid tumor regimens, and no need for travel by patients and specialists. So what I also saw is that Mount Isa became an independent or standalone chemotherapy unit, or I would say medical oncology unit, but hematologists also use it, with fully staffed and providing more services, or almost comprehensive medical oncology services, supported by telemedicine, medical oncologists via telemedicine. So this is the model we are trying to achieve in as many towns as possible, so that you keep shifting the specialist services to the rural sector, resource them adequately so that every site becomes more upskilled. So this is one of the observations or lessons I learned over the last 5-6 years. So as I said, through telemedicine, we were able to improve the specialist services to rural towns. That obviously expanded the scope of practice, the Mount Isa experience. And because of the expanded scope of practice, the workforce has increased. And workforce is a complex thing. I'm just using a simplistic approach here. Better workforce, now we are able to provide better services. So it's a virtuous cycle. In this case, what also happens is, so your rural service capabilities have increased, improved, scope of practice has expanded, and the workforce has increased. So telehealth for me is not just for seeing patients, it's actually one way of improving rural sectors' capabilities. So as I said, if you are implementing new models of care, the governance and quality assurance exercises are fundamental, because otherwise you cannot justify or you cannot defend yourself. So morbidity, mortality outcomes, they are coming because it's a long-term results, long-term studies. Quality of life for patients, rural workforce and providers. Satisfaction levels by patients and receiving health workers. Safety is fundamental here because we deal with toxic stuff. And also cost effectiveness and cost comparisons. So this is patient satisfaction levels with telemedicine models. So we have few models around the world who do tele-oncology models as comprehensive models. One group in Kansas, USA, and British Columbia, Canada. And also we have done similar studies with our patients. So summary is that the patients like it, as more than 90% of them preferred VC than traveling to Townsville. Health workers actually want this model because they feel that it connects them with the specialist or connects them with the outside world, so they don't feel isolated. So for me, these kind of cohort studies or a series are adequate to reassure that this is a satisfactory model. And some of my academic colleagues asked for randomized controlled trials. I said, honestly, you'll be waiting for 25 years because rural health doesn't give you enough numbers to, or enough power to give you randomized controlled trials. So this is what we have, and I think that's good enough, because if you're relying on pre-election polls for predictions, then this is better than that. And then the other theme is indigenous perspective on telehealth, because there's a lot of indigenous people living in remote communities, and people are concerned about cultural aspects and whether patients are happy to be seen on TV or not. So we did the same questionnaires and also some qualitative component. I actually never came across a single word on cultural issues as part of this evaluation. It was same issues like distance, isolations, and travel, financial issues as non-indigenous. And they love it, and the communication we have is fantastic, eye contacts. And so my philosophy now is to really, when we talk about doctor-patient communication skills, it's really same approach, whether they are black, white, or yellow, but you just have to address, understand the patient. So you could have a patient with non-indigenous background who has low levels of education. You talk to their level, and you might have an indigenous patient who's highly educated. Then you actually have to tailor your conversation in a different language. So for me, I really didn't feel that ethnicity or cultural backgrounds interfered with telemedicine consultations. One of the major surprise was really the attendance by multiple family members, especially the indigenous communities. At the moment, I rather see a patient on telemedicine from indigenous communities than face-to-face. When I see someone in Townsville, I see a patient with a nervous escort, but when I see patients in telemedicine, I have at least 10 family members coming with the patients. So it is really now, it gave me confidence to at least prescribe oral chemotherapy in the rural communities, because I rely on the family for compliance. And also it educates the Aboriginal health workers. And now, because it's a family, it's a great forum to bring up prevention and anti-smoking education messages. So it is great technology for Indigenous, and they will thank you for it if you do that to their communities. What about doctor-patient communication? Again, our studies and also the current ongoing qualitative studies really found the rapport, trust, connections all achieved through telehealth. There's no problem discussing prognosis and hard stuff. In fact, it's actually easier to discuss prognosis on telehealth, not because you can hang up afterwards, but it's actually the fact that a patient is with their extended families, the fact that they have a nurse or doctor who know them well, and they have the Aboriginal liaison officers or even rural health workers sitting next to the patient. I feel much more comfortable discussing hard stuff than when the patient comes with a nervous escort, knowing that they actually have to drive back after hearing bad news. So I don't have issue with it, and I think a lot of my colleagues find the same thing. So the tip for doctors and patients here is that when you talk to someone on the screen, don't feel that you're actually talking to a TV. If you connect to that person as a person, then you will overcome the technology barrier immediately. Physical examination really, it's an old story, and if patients had CT scans, I don't do physical examinations, but there's a GP or doctor on the other end, so if you really think physical examination is important, then they will do it for you, but as you know, in medicine, most of the information is from good histories. So safety, again, as I mentioned, it's been paramount as part of our studies. One of our trainees, this is the good thing about having trainees, you can get them to do projects. So Brian presented last year at the COSA about safety of remote supervision of chemotherapy. So this is the Mount Isa safety figures. And what he found was the patients had same dose intensities and toxicities as described in the literature. And we're just finishing up comparing the Townsville figures. So it looks like the dose intensities and the side effects and the mortality is all the same. So I'm quite pleased that it is a safe model. Cost effectiveness or cost comparison is really there's a lot of studies on telehealth about cost of travel and etc. But they are really cost comparison because cost effectiveness is a much more complex health economic studies, and I don't have time for that, so I just did a comparison. So what we found was the establishment cost over 4.5 years was 442,000, and the benefits by avoiding travel, accommodation, urgent aeromedical transfers and specialist travel was 760,000. So I think around the savings of 300,000 just from a small department. And what we have now done, we know how much we save for Mount Isa Hospital, so now we are asked them to spend that money on a medical registrar. So they funded that registrar position. So that's again another way of improving rural workforce. So future directions. So the Mount Isa model is applicable to larger centers larger rural centers where there is more people, chemo competency nurses. But the small town, the people from smaller rural centers continue to travel. So how can we help everyone? How do we improve the workforce? Even as a specialist, I'm sick and tired of seeing patients with stage 4 lung cancer. So how can we chip in or take our part or play our part in improving access to prevention educations? So the barriers to chemotherapy administration in small towns, I have just outlined it here. Obviously, small towns have 2 or 3 nurses. They are generalist nurses. So it's really unrealistic or impossible to make them chemo-competent nurses because they do 6 months of training to give chemo to 1 patient a year. That's not a smart practice. And also because of the low numbers, it's hard to maintain competency. So we thought new models of remote supervision is important. So we thought we should really help the small towns. So if chemo competency in nursing is the limiting factor, then we'll provide that. We provide that via telemedicine. So telenursing chemo competency idea. So you limited specialist services is really the chemo competency nursing. So telenursing comes in, immediately it expands the scope of practice. So we thought, as Jon said, whatever you try to do, if you can do it at a system level, then it benefits more patients. So through statewide cancer network and rural and remote clinical network of Queensland Health, we are now in the process of finalizing a Queensland remote chemotherapy supervision model for the state using telenursing supported by teleoncology and telepharmacy. And we have already trialed this model in 2 different towns for the last 6 months in Ingham and Bowen. The excitement is really infectious and I'm pretty sure it's very easy to roll it out. So what the model is, you have patient here at the rural center supported by family members, rural generalists and nurses. There is a general pharmacist or outreach pharmacist. You do the medical review via video link. Say, for example, patient on, is suitable for initially simple chemotherapy regimens. So say someone on gemcitabine or Avastin Xeloda. Medical review by telemedicine first, and then the chemo nurse takes over, and then guide the general nurse to finish it up. And then the pharmacist also guides. And what happens, patients in every small towns now can receive selected simple agents. Obviously, with these models, we need to have strong governance, so training requirements, workforce requirements, and we are working through a 10-point plan. So one of the beauty of this model is that the rural nurse, according to our experience, only needs 3 days of some sort of clinical placement in a cancer center, and they should be able to deal with the cancer therapy, chemotherapy, supervised by a tertiary chemocompetent nurse via video link. Improving rural workforce. I was fortunate that I had rural rotations to Central Australia, and I don't know whether because of that I was interested in rural health or whether it was my rural upbringing in northern Sri Lanka. But whatever that was, I think there is enough evidence to say that people who are exposed to rural sector or worked in rural sector are likely to go back. So then it makes sense as a system that we encourage rural rotations for nurses, doctors, and allied health. And I think it has to be a compulsory part of any training program, so governments really have to force this issue, because there's no point in just training people in metropolitan areas who never been to rural sites. So that's, it should be at a system level. One of the issues, if you want to rotate patients, doctors, nurses, and allied health to rural towns, is the limited number of supervisors. So we have telehealth models. You have one-to-one supervision. So you can really provide the supervision and see whether you can improve the exposure. The rural GPs, I think they have shown that it is feasible to have trainees in the rural sector and supervised by video link. There are telesupervision of trainees funded by specialist training programs. And in Townsville, Mount Isa, as I said, because of the savings we showed to the hospital, they're now funding a basic physician trainee rotating to Mount Isa from Cairns or Townsville. And they are supposed to be part of the oncology unit. So they sit with the patients on my clinic days, and the patients are admitted under the trainees and obviously supervised by an internal medicine physician. But they get one-to-one supervision. So I'll just go to, because I have time, and I don't know how to fill 45 minutes, so I actually thought I'll slip in one of the videos taken by College of Physicians, and unfortunately it's the video of our model. But if someone, it's about 5 minutes, but if anyone is bored, please put the hand up and I'll pause it. So the next video is just going through some of the discussions. Without telehealth, it would be difficult to manage rural health in a cost-effective and a quality manner. We go to those towns through telehealth when the patient needs us. We just dial in whenever we are needed. Hello.
Good morning, Townsville.
Good morning, Mount Isa.
How are we today? We've got Cam with us this morning.
Yeah, how are you, Cam?
Not too bad, thanks, Dr. Sabe.
And I belong to Department of Medical Oncology at the Townsville Cancer Center. We have 4 medical oncologists here. We serve nearly 400,000 population, and we have about 21 rural towns that are part of our telehealth network. I also have a couple of our medical students here, Brenton, and there are a few telehealth courtesies we have to follow, same as face-to-face. So Shane and who else is in the room? We introduce ourselves to the patients, And I also make sure that I know who is on the other end.
Clinical nurse Jess.
Yes, hello Jess, where are you?
I'm here.
I'll zoom around and look at the room so that if there are any confidential information I need to share with the patient, I can manipulate the system or navigate the system. And I also make sure I introduce whoever is on my end so that they are comfortable that there's no one else is listening into it. So how is the chemo going so far?
Yeah, pretty good. Bit tired, but other than that, it's fine.
Can I have a look at it?
Yeah.
Nice and clean, and doesn't look infected, and it's not painful?
No, not at all. I'm really impressed with it.
Yeah, no, that's actually, they have done a good job.
Yeah.
So we'll just keep that in during the chemo and then take it out once we are happy. It took us 5 years learning, looking at our strengths and weaknesses. We did safety audits, satisfaction surveys, we did cost-effective analysis. We kept addressing every little issues came up. Now it's almost a flawless system, but we're still learning. So I'll just show you your scans, and half of our consultations are quite interactive, and I use CT scans or pictures that I have on my desktop so that it adds another dimension. It's about, can you see the cursor?
Yep.
So basically this liver, you don't want any holes in it, black or grey holes, so as long as it remains like this, to me it all looks nice and clean.
I think it's a great service. You know, it saves me 1,000 kilometres. It's a day's drive each way. It'd also be a support person to go with me, either my partner or a family member or something like that. It's a face-to-face without the hassle of having to travel, basically.
You'll keep them in the community without having to bring them into hospital, reinforcing the simple management processes. So it's often a very good case discussion to see how everybody interrelates and how you can ensure that everybody is on the same level so that we have a better understanding of not only the care needs for the person but also how the management program integrates between the various aspects of the healthcare team.
Absolutely. So would the protocol be to reduce the dose of oxaliplatin?
I mean, that's something you've got to have a judgment on it, because remember, because these are for cure.
Now maybe 12 hours away from Professor Sabe in Townsville, but with the telehealth, it's like he's in the room.
Yes.
You've got to make sure maybe maintain the dose intensity while we are looking at the side.
It certainly offers me unique abilities to have exposure to a specialty in a rural area with good supervision and good support. I think it's very effective in making patients more compliant with therapy and attending clinics.
We have patient satisfaction surveys showing that there's a high level of satisfaction, and that includes indigenous patients. And they come as a group of 8 to 10 with their family members. So now we are able to engage with the family, which would never happen in face-to-face. And now we discuss prevention strategies and how the cancer was caused in terms of smoking, etc. on telehealth. So that's a real surprise that we are engaging with extended families. So thanks Shane, thanks Jess, and Cam, good to see you again. So I'm really pleased with the way things are going. And Shane, if there are any concerns, just call me, or Jess, if you have any concerns, just call me, I'll dial in straight away.
Excellent, no worries.
So see you in about 9.
Okay, mate.
Bye-bye.
Bye-bye.
Our philosophy is that it is another tool to provide our service. So we have embedded telehealth as part of our day-to-day business. All we have to do was dial in and start the conversation. Every field, telehealth has an application. So if you want to help your rural patients so that they receive your services closer to home without disruption to their family lives in an equitable manner to urban patients, then telehealth is a tool for you. So thank you for that. So yeah, so that's just to demonstrate what happens and the training aspects of telemedicine. So I'll just talk a couple more slides on the next aspects. So that's really prevention education. This idea came because of telehealth. And one of the observations with indigenous health is that half of the indigenous population smokes, and any prevention measures have to be family oriented. So I felt that there's no point in talking to one person about smoking when they are going back to everyone who is smoking. So similar to everything else, access to public health is limited in rural, remote, indigenous areas, and the public campaigns may not reach or relate to everyone. So this is where, especially for indigenous communities, more hands-on programs are important. And one of the examples we've been embarking on or started already is a model called My Fate. So that is My Family's Anti-Tobacco Education, where the specialist who looks after a patient with smoking-related illness becomes a mentor for an extended family of that patient. And over 6 months, using face-to-face meetings and video conferencing, see whether we can transform the thinking process in the families. So that's, I'm quite excited about that model, and hopefully we'll get some knock-on effect, societal benefits. So before I wrap up, so my experience and the experience in the literature is that telehealth models of care can reach or provide services to the spectrum from prevention, early diagnosis, to follow-up and treatment. And unfortunately, fortunately, it also has many other benefits. So it has many benefits for patients and health professionals, financial benefits to the health system. It will help enhance rural capabilities and expand the scope of practice. And I think it needs to be part of core business of all health systems who care for rural patients. And one of the things we have done in Queensland through the rural networks is that now the PTSS form is, I think, the travel subsidy form. It has one box. It says, is this service available, or is telehealth is available? If someone ticks that one, then the hospital won't fund that travel. So now it's forcing people to look at telehealth systems. So that's all I have to say, and thank you for listening.
So now all we need is cloning technology. So we can clone you. Question? Yep.
Yes. Yes. Thank you very much, Associate Professor Sabesan. I am Dr. Sivistai Thamarangsi from Laos, and I am PhD candidate in University of Sydney. And I appreciate your talk, and your situation maybe would be better than my country. You are in the remote area. I have 2 questions to ask you. One regarding to the healthcare provider, and 2 regarding to the patients. To the healthcare provider, as you face a lot of barriers, you have seen already, and are there any motivation to encourage your healthcare provider to work in your remote area? I mean, facilities of the accommodation for your healthcare provider, or any other incentive that encourage your healthcare provider to work in your remote area. The second one for the patients, that I presume that healthcare provider or Medicare would cover your patients. And how about the travel cost for the patient to transfer for having further treatment? Yes, that's it, my 2 questions. Thank you very much.
That's okay. So in terms of providers and encouraging, obviously, it's an ongoing process, and I think it has to be at all levels, individual levels, departmental levels, hospital levels, and government levels. And government levels, obviously, you can mandate rural rotations, and some of the colleges and training programs actually mandate some part of rural rotations. but also if every health system start thinking about their responsibility for all the patients, then they will also make it part of their systems. And a simple way of doing it is actually, if people are interested in rural health, you just keep talking about it. So it is a cultural issue, and not issue, it's a cultural challenge, but it will take time. But in terms of patients, it is a costly affair, because it's not just paying money. It's one thing I learned when I was traveling from Mount Isa to Dumaji during the school holidays. We were camping, and I actually always talked about travel and inconvenience and the distance. I never factored in punctured tire as part of it. So then I thought, there's another reason to do telehealth, avoid punctured tires. So yeah, so it's really, it has many benefits for the patients.
Okay, one last question, please. Whoever was first,
Hi, my name's Chloe Medell. I'm a telehealth manager for New South Wales Health. I was just wondering if you're able to briefly touch on more about your funding model, so whether it's covered by Medicare or activity-based funding, because that's the big issue here that we face within New South Wales.
Yeah, so in terms of funding, at the moment it's actually everything I do is covered by Medicare, and it's actually 1.5 times your normal Medicare billing. So if you are interested in money, then it's actually a good way to do it. But we started telehealth long before Medicare services were available, simply because I was a staff specialist, a salaried medical officer, so I just do these things as part of my job. And that's if you are in a public sector, and I think that's everyone's responsibility. You work during those time and provide the service. So now you can bulk bill. So the specialists are covered. And if the GP is sitting on the other end, obviously they can bill the consultation. And the activity-based funding is mainly for treatment. So if you're doing treatment in rural towns, then they should get their activity-based funding for that particular occasion of service. And that means that whenever I shift a patient from Townsville to a rural town, the towns will lose the ABF funding, but really you're talking small money, but that will make a big difference to these rural patients. So funding models, I think they are pretty straightforward in my book.
Okay, thank you. I'm sure Sabe wouldn't mind if anybody else wanted to ask a question to come up at the end, but please join me in thanking both of our speakers this morning. And so the morning tea's outside, and the concurrent sessions start at past promptly. Thank you.